Good afternoon. Welcome to Median's webinar. My name is Iannessi. I'm the moderator of today's webinar. We're very happy today to bring you a very interesting topic to discuss the main course of variabilities in centralized oncology radiologic assessment. We have two speakers today, Dr. Antoine Iannessi, our medical director. Antoine has more than 10 years experience in both academic and industry. And he was also the former head of Interventional Oncology Department of Cancer Center, Nice Unicancer. Another speaker is Dr. Emilie Serre, our clinical research scientist. Emilie owns a PhD in molecular and cellular biology, focused on oncology. She has also been managing clinical trials from the late phase to the preclinical phase in the past 10 years. And she has also been a project manager at Median for more than 6 years. A practical reminder for you that you can submit your questions during the presentation in the question panel, and we will answer all your questions at the end. Before we move to the next topics, a very brief introduction about Median. Median is a leading AI-based next-generation precision medicine company. We focus on providing solutions on helping conquer cancer and other disease, and also provide imaging testing and service for drug development. With our office based in US, Europe, and China, we operate globally to deliver best-in-class end-to-end imaging service for your oncological trials. Now, let's welcome our first speaker, Dr. Antoine Iannessi. Antoine, the floor is yours.
Thank you, Ian. Thank you for this nice introduction. And let's go on for this very interesting topic today. And I'm sure that what we're gonna explain will be a field of interest for all the attendees. So I would like first to summarize the teaching point for the next 30 minutes, and we will describe the most common type of reader discrepancy during an oncology follow-up. We will also explain strategy of control and prevention of those causes of viability during the centralized independent review. And finally, we will also describe the viability metrics that are used to monitor the quality during the independent central review. So to start, it's really important to actually put the context. So what is the blinded independent centralized review? The centralized review consists in submitting image from the image center to a centralized core lab. That means that we have the same image, which is submitted to two different radiologists, and those two different radiologists will have the same reading instruction. However, their opinion regarding the drug efficacy assessment can be different, and it can be different in terms of response, on the response status of the patient, or in terms of progression status. So here we speak about a discrepancy. When we speak about reading instruction, we want to say that those reading instructions are usually based on an oncology criteria. And those criteria, the most common is RECIST 1.1 for the solid tumor, are normally built the same way. So with partly with a disease that will be quantified and recorded under a target lesion during the baseline evaluation, and partly of the disease will not be evaluable on a quantified methodology, but then it will be qualified, and so part of the disease at the baseline is not quantified, and it's just we just give a status for this disease. Then comes the follow-up, and during the follow-up, we will use the same methodology. So regarding the target's pool of lesion, they will be measured the same way they have been measured at the baseline, and for the non-target category, they will be again qualified for their presence or disappearance during the follow-up. An additional category comes during the follow-up period. regarding the new lesion. And this new lesion is very important because the appearance of a new lesion usually under the criteria will trigger a progression. So thinking about these criteria and these three categories, it's possible to actually divide the variability factors according to each category. For example, for the target lesion that are measured, according to this measurement, there will be thresholds that will trigger progression or response. And here you can see that one variability factor can be the measurement itself. So variability on the measurement can lead to a certain type of discrepancy. For target lesion and non-target lesion, there is an initial selection of those lesions. So this initial selection can be different between readers and will trigger a certain type of discrepancy. We will see that in the next part of the discussion. What is really important to understand here is that both for target lesion and non-target lesion, there is some qualitative assessment involving, and this includes for target lesion their disappearance, especially for small lesion. We will have some example. For non-target lesion, most of the assessment is qualitative. All the assessment will be based on the status and disregard the progression in terms of significance, their pathological significance, and the disappearance of small lesion. For new lesion, the main reason for the discrepancy will be the rate of detection. And here, again, we will have some examples. But for new lesion also, there is some qualitative part in terms of assessment, especially regarding the equivocality of the lesion when they first occurred. So keep in mind that even though the reading rules tend to standardize and to provide an objective analysis of the disease, mostly for each category, there is always a qualitative and subjective assessment that is required, and this will lead to often discrepancies. When we look at the literature, indeed, and this is taken from 40 oncology trials, we can have an idea of the inter-reader discrepancy rates. And when we look at the type of discrepancy, so the type of discrepancy, meaning that discrepancy can be on the progression or it can be on the overall response. So the reader can agree on the time of progression, or they can agree on the best overall response. And we can see here that the disagreement is between 20 and 30% of the time, depending of the variable of agreement. Now, when we look deeper inside of the cause of those discrepancies, we have a representation here that shows up very important information in terms of actionable strategy of control. Indeed, on this large analysis, it is mostly reported that the difference in lesion selection and the perception of new lesion, they represent 2/3 of the cause of discrepancy. So if we can prevent those type of causes, that means that we will have a large action on controlling the discrepancies. So how can we actually monitor the variability? So it's really important to understand that the idea here is to control the variability. We can get a 0% variability, but there is always variability, so you have to accept it. But there is a way that we can monitor and give some good insights in terms of control strategy. And I would like to share with you some results of monitoring investigation that are actually very useful to understand the cause of discrepancy. Indeed, there is 4 main factors of variability between 2 radiologies. We have seen previously that 2 of them represent already 2/3 of the variability. So let's speak about the initial selection. The initial selection can be divided in 4 types of variability causes: the accepted variability, the lack of knowledge, the equivocality, and the classification of the lesion in terms of organ or localization. What is the accepted viability? The accepted viability is the variability that is accepted by the criteria. So the criteria is a reading rule that allow some room for variability. Here, it's an example of a selection based on RECIST 1.1 criteria. And we can see the ideal selection, which report all the lesion in the liver. But basically, another reader could have selected two different target lesions. He could have grouped the non-target lesion as it's allowed by the criteria. There is also some incomplete non-target lesion, but per se and for feasibility, it's not a must to report completely all lesions if they are actually reported qualitatively. So here we can see that already inside of the criteria, even though there is a standardization, there is a room for variability. And then it can be even more variable in terms of selection. The selection could be a little bit less compliant to the criteria. Let's say here that this reader selected not the largest lesion as RECIST 1.1 advice, but he has selected a small lesion here. So if there is no rationale behind it, there's a question of representativity. So this type of selection will question the monitor. Here also, if there is only one lesion, while there were more than one lesion selectable, there is a question of representativity. But for all these three cases, if there is a good rationale in terms of reproducibility of measurement, for example, and there are examples, it cannot be considered always as an error. So that's why it's really important to train readers to choose unquestionable lesion and to train them to be the more representative and the more completeness in their initial selection. That's really the message here. Try to be the more representative at your baseline selection. In rare cases, there could be variability of the selection, which is due to lack of knowledge. So the lack of knowledge can be linked to the criteria. In this case, we speak about the non-compliance of the criteria, but it can be also linked to a lack of knowledge in the oncologic disease. Here it's an example of a selection that was non-compliant for RECIST 1.1. The reader selected one target lesion, which is blastic in the bone, and per RECIST 1.1, this type of lesion should not be considered as measurable, so they cannot be recorded under the pool of target lesion. This is a second example where one cavitary lesion also, which is normally not considered as measurable, was selected as target lesion. So here is really a non-compliance with respect to the criteria. In this case, it's more lack of knowledge in terms of the oncologic disease, selecting this benign lesion with a fatty content of the adrenal gland, which is not linked to the oncologic disease, but and will not be, we should not be followed for the oncologic disease. So here, if we want to control those type of variability, it's indeed to select experts. So really radiologist expert in terms of oncologic follow-up, and also train the expert on criteria. Another option also is actually to use some specific software, as we used in Median, which will look for non-compliancy check after each read in order to help the reader not to make any error in terms of compliance. Third reason for baseline selection discrepancy is the equivocality. This is actually frequent, and it's not rare at baseline that we have a selected lesion which are equivocal. So here it's an example with this small adrenal gland selected by one reader at baseline. How do we know that this was not a correct selection? Because when we have the follow-up, you can see that this lesion, which is 14 millimeter, will never change size, while the rest of the disease will change. So it's probably not linked to the disease. Here, same idea, but captured inside of the non-target lesion pool as a lymph node, which is between 10 and 15 millimeter per RECIST. Those lymph nodes are a little bit equivocal in size. We know that they can be pathologic if they are measuring more than 10 millimeter, but their specificity is not 100%. And in this case, this lymph node was probably not linked to the disease. Here, another case, more linked to the size, initial size of the lesion. When you have a small lesion, it's obviously not always specific, especially in the lung. And here it was recorded. So these type of events are actually common in central review. They are linked to the central review paradigm, which censor the reader of the anteriority of imaging, for example, and there is sensor information that will lead the reader to include lesion because the reader, per definition, in the context, will think that this lesion is suspect and part of the disease. So we have actually wrote an article on this topic recently, where we show that if you include those type of equivocal finding at baseline inside of your target lesion, what will happen? You will shift the threshold of progression and shift the threshold of response. So we advise for those cases to our reader to better include them in the non-target lesion to be able to qualitatively select or deselect them during the review and not influence the disease when it's measurable. Another option is to include in your paradigm of reading a global review at the end of the evaluation for each patient to actually trigger those type of lesions that are equivocal at baseline and were not probably linked to the disease. Second main cause of variability is linked to the new lesion detection. So here we have four type of use case. There is the phase alarm, the phase detection. There is a non-detection, there is a delay detection, and there is the under detection. So about phase alarm and so phase positive of a progression, basically. Here are four examples. The first one is linked to one reader stating a new lesion as a lymph node here. But when we look at the baseline, actually the lesion was not new. So the first definition is indeed to always compare to the baseline because the definition of a new lesion has to be new. So that's actually it could. It seems that this cannot happen, but it's often, of course, here it's an equivocally situation, but sometimes when you have a small lesion, it's not something unequivocal, and it can lead to a definition of new lesion while they were already at the baseline. Here, the second case is about the equivocality of this new lesion. So we have a detection of a small micronodule in the lung. This micronodule has been stated as a new lesion, but sometimes those new lesions are not linked to the disease. They can be linked to inflammation. So in this case, RECIST 1.1 provide advice to act for an active follow-up of those lesions and use the next time point to clarify the situation. So here, 2 time points after, we had the exact same lesion, no growing. So in this case, we could consider that this was probably linked to an inflammation. Here we have a third case, which is more linked to specificity in terms of criteria. And in RECIST 1.1, the lymph node, to be considered as pathologic, they must measure more than 10 millimeters. So as we know that lymph node is often more equivocal situation, when you state a new lesion based on a lymph node, it's always important to be sure that this lymph node actually measure more than 10 millimeters. And this is actually valid also for new lymph node that would be necrotic or very specific. The criteria is very precise, and you should consider really the size as the criteria of saying if the lymph node is pathologic or not. And then a last case, which is a bit different, and regard the appearance of blastic bone lesion. So this is quite common. This situation is reported during the treatment of a patient with a disease, especially early after the treatment, and it's not linked to a progression, so we should not be understood as appearance of new lesion in the bone, but more about an effect and a positive effect of the treatment, and this is more a healing reaction of almost non-visible lesion at baseline than a progression. It's called a bone flare, and normally our readers are trained to detect such a scenario. So if we want to prevent the false alarm, we advise to always compare the lesion to the baseline. We advise to confirm small lesion with new time point. We also advise to always measure new lymph node in order to capture lymph nodes that are not pathologic, and to be aware of the bone flare scenario. Second cause of discrepancy regarding new lesion is the non-detected new lesion. So non-detected new lesion, it's often linked to specific localization. So we can look into bone lesion, and they represent the majority of those cases. Bone lesion can be missed. They can be missed because probably of the fact that sometimes they are not always very visible in terms of conspicuity. They also need sometimes reformatting. The second cases, and this use case is actually a new lesion that are missed in expected locations, such as liver, such as adrenal gland when we follow a lung, and this can happen actually. And the third type of cases is linked to unexpected locations. So when you have a new lesion that will be found in specific places where they are not expected. So here we have a rationale to explain the non-detected lesion. But still, there are three different use cases. So what can we propose to control the non-detected new lesion discrepancy is to adopt a checklist behavior for the reader in order to fight against the attention bias. So having a checklist, including a windowing in the bone window and a reformatting, will help to detect always for each patient, each time point, the new lesion that could appear in the bone. That's really important. And if you have a checklist, you can also always look to unexpected location. Third cause of discrepancy related to new lesion is not the non-detection, but it's linked to the delayed detection. This is an example with one reader stating one new lesion at week 18 based on this lymph node. The reader 2 also saw the same finding, but he found this finding one visit after. So in this case, we have a discrepancy between those two readers in terms of date of progression. This is actually more frequent than non-detection. So we advise to the reader to always look at the previous time point after detecting one lesion. So in this case, this reader should look to the previous time point in order to actually see if he was not missed before. The third cause for variability is linked to the non-target assessment in terms of progression or response. And here we have one main cause for this variability, which is linked to a paradoxical or unsynchronized response between the target pool of lesion and the non-target pool of lesion. So paradoxical means that when you have a target lesion, for example, that responds, you will have a non-target lesion that will increase. And unsynchronized response means that if you have the target lesion that responds, you might have also a non-target lesion that responds, but the nadir will be delayed before. So the intensity of response and the time of response can be different between the two categories. Here we have a case where the patient had the one lesion here that was measured, the target lesion. The target lesion is stable. As you can see, most of the target lesions are stable. But for this patient, the non-targeted lesion initially increase. So here we have a kind of a paradoxical response between the target and the non-target response. So this type of scenario will lead sometimes to variability, especially for detection of such change, because there is a kind of a tunnel vision. The radiologist will be inside of his assessment, considering the patient is stable, and sometimes this type of increase are not actually correctly detected, especially because the reading workflow is most of the time point by time point. We will detail that on another use case. For monitoring strategy, we can always propose to compare the non-target pool to the baseline and to their own nadir. So basically, what we can advise is to ask the reader to look sometimes and to try to understand if the nadir of non-target lesion and target lesion are the same. Because just by having this, making this effort, we'll understood what is the global response of the patient over time. Last reason for discrepancy is the measurement of the target. So here we have the first cause that is linked to the data set. So let's say the patient and the patient evolution. So in this case, it's a good illustration where one reader and the second reader will choose the exact same target, but linked to the patient evolution, the measurement will be more difficult to assess. The measurement will become variable in their assessment due to the lesion that will become a cavitary. So here we have one reader that measures the lesion this way because they consider probably that this part is not linked to the lesion, and here the measurement is larger. So the consequence is high for the patient because the reader 2 will state a progression while the reader 1 will state a stable disease. So we can see that there is part of the measurement, even if we try to measure it in the most standardized way, there is some subjective part in this measurement, as we previously said. About limit of standardization, this is the second cause of discrepancy in terms of methodology of measurement. So here it's an example where the two readers will select the same lesion, but the initial measurement will be different. And it will be different because the method is different. One reader will not include the rim here, and he has selected the lesion on the portal phase, while this reader will select the lesion on the arterial phase and will include the rim. But the difference is quite important because for this small lesion, we have a difference of at least 10 millimeters. So you can imagine that it can have a huge impact, especially for patients with not a lot of tumor burden. This can happen actually longitudinally on the same reader, because if you don't select the same phase during your measurement, here we have a portal phase, and here we have an arterial phase. The measurement can be different, and it can simulate a change on the lesion, which is not a real change, and it's just linked to the phase of use for measurement. So the methodology has to be very standardized, keep the same method, keep the same windowing, and keep the same phase over time. That's really part of the quality control. I was speaking previously about the problem of attention and the tunnel vision. So in oncology follow-up, there is something to know. There is a common bias, which is called anchor bias, and also linked to an attention bias. The attention bias is linked to the tunnel vision. So what does it mean? It means that when we assess a patient, we often assess it time point by time point. You rarely have a global overview of everything. You continue to measure your lesion like this. And if you look at those assessments, you see that there is probably, when you look at it, a stable disease. So this patient has been selected with 2 lesions. Here is the nadir, and here is the last time point. And the measurement seems to be very stable. But when we have a global overview on this patient, we can see that between the nadir and between the last time point, there is actually an unequivocal progression, which has been missed by the reader. So it's linked to this type of attention bias, which lead the reader to reproduce the same measurement over time, while the disease is obviously not stable here. So how can we prevent that? We have two possibilities. As we said, it's really important to look for the nadir of the non-target lesion. This will greatly help And also, in terms of paradigm of reading, it's possible to include a global review, giving a global overview of the patient evolution. Last reason for measurement discrepancy is about the scarce respect to complete response. Here we have one reader stating one lesion here, and the second reader for the same lesion. They will follow this lesion over time, and at one point, one of the reader will consider that the lesion has disappeared. The other reader will continue to measure, and there will be a discrepancy in terms of response here, because one reader will consider the patient as a complete response, while the other one will consider the patient as a partial response. This regarding the subjective opinion in terms of should I consider this as a scar or not? And we don't have always the answer in it. So I hope this was helpful for you to understand really deeply what are the most common reasons for variability in terms of really use cases. Now I would like to give the microphone to my colleague. She will give another approach linked to the metrics and how we actually can monitor the study using metrics to see if we have to do some investigation or not. That's so, Emilie, I give you the microphone.
Thank you, Antoine. So as you just heard, the variability in the radiological assessment is an inherent and critical factor of the independent central review. And so it's going to be major responsibility as an imaging CRO to monitor the variability and ensure that it is kept within acceptable standards, which is depending on the pathology, the type of study, and also the type of disease. For monitoring the variability, we are following up 3 major metrics at Median that I will present to you shortly. Median has developed an online reporting tool which allows to monitor these metrics in an ongoing way and to take the necessary action in terms of reader retraining. The statistics are a very useful tool to be proactive in risk and quality analysis for your study, and will help to limit any potential delay and associated additional cost related to this quality issue. So these 3 major metrics are that we are following are the discordance rates between the 2 readers' assessments, the adjudication rate, and the endorsement rate. An important metric to follow up is the discordance rates. It's computed for each reader and corresponding to the number of discrepant cases on the total number of cases assessed. Depending on the study workflow, the adjudication is performed ongoing at each new discrepant visit, or more often when a subject is considered complete, which means that all visits have been read by the 2 readers and that the subject has no more visit expected. At Median, the monitoring of reader quality is triggered at 25%, 50%, 75%, and 100% of the total expected rates. The 25% milestone is usually happening very early in the study and at the beginning of the enrollment progress. So usually few or no adjudications are done. In that case, the most reliable metric is the amount of discordances. This is a key information to monitor the global health of your study, and this according to literature, of course, but also importantly to the medical monitor experience. And you have here an example of discordance rates calculated per reader into Median online reporting tool. So this use case is a non-squamous cell lung cancer phase 3 study. The imaging endpoints are the progression-free survival and the overall response rate. We are following here per reader the number of discrepant cases and the total number of cases they have assessed. If you focus on the percentage of discrepancies on the date of progression or the confirmed response, you can see that for all the readers, the rates ran from 18.37 to 28.89% of discrepancies. The expected literature discordance rate for this study is 30%. The 4 readers, as you can see, are not outside of the expected range, and median medical monitor will most probably not take any specific action in this case scenario. So as the study is progressing, of course, the number of adjudication of subject completed, and the associated number of adjudication going to increase. We can thus monitor the adjudication rate in addition to the discrepancy rate. So what is the adjudication rate? It's the number of subjects adjudicated on the total number of subjects read at a study and reader level. It is highly recommended to consider the adjudication rate cautiously when monitoring the assessment variability, and to not take this metric alone to conclude on the data quality. So why? Because this metric is highly dependent on the adjudication variables that have been selected for your study and that are described in the imaging review charter. It also depends a lot on the type of disease and on cases complexity, like, for example, poorly objective disease or some pleural lesions that might create, of course, more cases of discrepancy and adjudication. Also, an high adjudication rate could be more simply attributed to an outlier reader. So as an example here, you can see an extract of the Median online reporting tool that shows the adjudication fraction with the corresponding confidence interval, both at the study level and the reader level. So Median Medical Monitor will confront this rate to an expected rate as per literature, and again, according to his own experience. The third and last metric that Median is following up is the reader endorsement rate. So the endorsement rate is the percentage of subjects for whom a reader has been chosen by the adjudicator in case of discrepancy with his paired reader. Median reporting tool, online reporting tool, is providing an interesting chart to monitor this endorsement rate that is called the P-chart. The P-chart is a graphical representation of the evolution of the endorsement rate along the study for a dedicated reader. So for statistical relevance, the endorsement rate is calculated at median for a minimum of 30 adjudications, and they will constitute batches. So below here, you can see the batches distribution and their length from the first to the last adjudication performed for this reader. The vertical orange line here shows the theoretical monitoring milestone at 25, 50, and 75% of the total expected read, as I explained in the previous slide. So above this graph, you can see the corresponding evolution of the reader endorsement rates for each batch of 30 adjudication. And the red line that you can see here is corresponding to a rate of 25% of endorsement that is the lower acceptance threshold, which means that any endorsement rates that will be under this 25% line will probably raise a red flag to the medical monitor. He can then decide to analyze some of the discrepancy more precisely for this reader before taking any further action or retraining. For example, you can see here for this doctor that we call Dr. X, he has a low endorsement rate here that is under the 25% threshold. And Median Medical Monitor decided to retrain the reader after the 50% milestone. And so you can see here in this graph, the positive evolution of the reader endorsement rate before and after the date of retraining. So you now have a clear vision, I hope, of the three metrics that we are using at Median for monitoring the assessment variability in your study. And I will let you, Antoine, summarize the main point of today's webinar.
Thank you, Emilie. That was very interesting. So, indeed, today we have seen that the criteria is basically a standardized reading instruction. So RESIST is a standardized reading instruction, and it's not standardized enough to provide 0% discrepancy. So there is a variability between readers. There can be some error, and this variability is linked to the subjectivity in terms of opinion and discrepant opinion between the two readers. Consider that the discrepancy rate is rarely less than 25% for a central reading, an independent central reading. The two most important causes of discrepancy are reported to be the baseline selection and the detection of new lesion. They represent 2/3 of the discrepancy. So the action in terms of control has to be really aimed to decrease those type of variability. And if you have to consider the metrics that you will follow during your central review, there is 3 important metrics to keep in mind. The discrepancy rate, which is earlier available, as Emilie explained, respect to the adjudication rate, can be considered independently or compared to the same type of study in the literature. There is the adjudication rate, which has to be always considered respect to the adjudication variable, because here again, we have a variability, and if we want to compare to something comparable, we need to speak about adjudication regarding a specific variable of adjudication. And at the reader level, endorsement rate and p-charts are very interesting metrics used to actually trigger outlier in terms of quality of readers. So I hope those information were very useful. Now I think it's time for us to go for a question. And I'm sure you will have more than one question about this topic. So here we have one question, which is, could the two readers choose different lesions? So indeed, two readers can select two different lesions at the baseline, and this is actually one of the main reasons for variability in terms of assessment. RESIST gives some rules. All the criteria give some rules for selection. But of course, the presentation of the disease can be different between every patient, and the criteria itself cannot cover all the use cases. So there is always a room for variability. So yes, the two reader can actually choose two different lesions at the baseline. Okay, we have here another question. So when you detect the reader errors during your monitoring, what are the actions you can take? So this is an interesting question. Actually, when we detect error, that means that we have already some metrics that are showing us that maybe there is a problem here. So we will look into those cases. And here we have two different actions that we can do. The first thing is to understand the reason of the discrepancy. So we really actually perform an investigation, as I explained, to understand what was the reason of the discrepancy. It can be linked to the selection, etc. And based on that, we try to understand how we can retrain the reader, and we provide a retraining not only to one reader, but we like to share the variability of one reader with the whole pool of readers, because we consider that these are really valuable insight for everyone to actually diminish the variability and also improve their quality. So we have a lot of questions. Another question is, what do you use as a quantitative measure for non-target progression? So actually, non-target progression is normally non-quantitative. So the specificity of the non-target lesion is that they are assessed qualitatively. However, we have some rules and advice to consider this category globally, considering the rest of the category, knowing the target lesion and the global disease to understand if the increase of the non-target lesion is considered as significant enough respect to the overall evaluation. So there is no, we can't give a specific rules and we cannot quantify it, but here it's really important to consider the whole disease. So here we have a question for you, Emilie. So there's a question about adjudication, endorsement rate. Is this available in real time or only at a set time points?
I want to be sure I understood the question. So do you want to know if the metrics that we have for adjudication rate and endorsement rate are available at any time during the studies? So the answer is yes. Thanks to the tools that I presented in my slides, it's allowing the medical monitor to check the study on an ongoing way. So those metrics are available all the time. Now, per our procedures, we have to in a mandatory way to monitor the quality of the reads and the adjudication rate and endorsement rate at dedicated milestones that are the 25, 50, 75, and 100%. So a report will be edited at this time. And those are mandatory steps, but it doesn't prevent to do an ongoing quality check if it's needed, especially for complex studies with a lot of variability expected.
Okay, so so we can indeed through this tool have those metrics available at ongoing, and these metrics help us to trigger monitoring. So there we really use those tools to investigate and trigger investigation. So we have maybe another question here. So if you have a new, this is probably from a radiologist actually, or a reader. If you have a new lesion, do you recommend going back to the first TP where it was first visible retrospect, even if it's a tiny pixel, or do you have a minimal reasonable size for calling a new lesion? So indeed, new lesion is a really hot topic in terms of progression. The equivocality of a small lesion, as you mentioned, is often appearing. So we have often difficulty to assess the correct date of progression. So what I recommend here is to act exactly the same with this category as you would act with non-target lesion. And this comes to the same previous question. So how do you consider that your patient is in progression? Should you consider actually that a very small tiny pixel could trigger progression to this patient or not? So there is a subjective part here in terms of when is the correct date of progression. I don't want to give a specific saying because it's quite often that we have actually difficulty to assess the correct date. The adjudicator having a global overview will endorse the correct reader, but there is we need to accept the variability as it is in terms of date of progression. I wanted to show actually cases of delayed detection that are obvious, but there are obviously also cases where it's not obvious and where it's really difficult to assess when was the first seen micro nodule. Should I actually consider it already as a progression or not? If you read carefully to RECIST 1.1, the answer is yes, but there is always room for subjectivity also in this category.
Maybe Antoine, the last question.
Okay, so I have a question here. How do you distinguish reader error from medical judgment during monitoring? So This is so the idea actually of the monitoring is really to investigate into the case with two objectives. First one is to trigger non-compliancy, the fact that one reader will not be compliant to, and this is of course a problem of reading error, because we have read rules, we have to follow the read rules. For the rest, there is a viability, and as we explained, there is no secure answer to say what is the date of progression. If you have some equivocality in a small lesion, you cannot consider this as a reader error. It's a simple variability, same variability that could be also possible on site or between colleagues when you actually read or reread a lesion. So it's not an easy answer. I would say that for sure, reader error is a problem of compliancy. This is a reader error, and also regarding lack of knowledge of obvious oncologic semiology, I would say, like as I explained before, with the detection of of bone flare, or misunderstanding of lesions that are benign, obviously benign. So yeah, for the rest, unfortunately, we have to accept the variability. The idea is not to reduce it to zero, because variability provides also information. Have to consider that without discrepancy, there is no adjudication. And the adjudication is an added value also in terms of selection. It's not because two readers are concordant that they have the truth. Sometimes you can get better information when you have a discrepancy and an adjudication than when you have two readers concordant. So I would finish with this positive opinion in terms of discrepancy.
Exactly, as you said, that by criteria itself, the variability, the discordance will exist. However, when we know the cause of this variability, we may control and mitigate those risks. And I think all what we discussed today is how can we decrease those variabilities. And I see that thanks Antoine and Emilie for the excellent talk, and also our audience. You raised very good questions and also allowed us to have a very interactive discussion. No worries if we don't have time to answer all your questions. We will reply to your questions personally to your email. And also, if you have additional ones you do not have time to submit today, you can always submit it to the info request at mediantechnologies.com. And also, today's session will be also available on the LinkedIn, Twitter, and our website in the coming days. So if you want to read it again, you can always watch our videos. So thanks a lot for your time and joining our webinar today. And we wish you a very good day and hope that we will meet again at our next session webinar. Thank you. Have an excellent day. Thank you.
Thank you.
Thank you.